Hi guys, welcome back to my YouTube channel. Today we'll read about breast. So breast is a modified sweat gland. So in this video we'll see about surgical anatomy and if a lymphatic drainage, and if a patient comes to you with a lump in the breast, what we have to do. So for the steps like triple assessment, and we further discuss about triple assessment, which include clinical examination and history, first part, and radiology, second part, and histopathology, third part. So this is what we are going to read in this live session, which is part 1. So first of all, we'll read about anatomy. So breast is a modified sweat gland. We have to read about anatomy now. So first we'll see the extension of breast. So vertically and horizontally. Vertically it extends from second rib to sixth rib. Sometimes it may also extend from clavicle to eighth rib. This is vertical extension. And horizontally it extends from sternum to anterior or mid-axillary line. You know axillary, right? Superaxillary, mid-axillary and infraaxillary. So anterior or mid-axillary line. So this is what the anatomy, and sometimes axillary tail of spines, which is a breast tissue that goes into the axilla. We know the anatomical part, right, which we read in first year. So sometimes a prominent axillary tail of spines is mistaken as a breast one. So we have to take in observation when we see a lump young 18 years old females or young age women. So we'll see the anatomy. So breast lies over pectoralis muscle. So above the muscle it has pectoral fascia. So the breast may be sagging downwards if they don't have any support. So suspensory ligaments of Cooper support the breast, which is more in the lower half of the breast. So we have seen the anatomy part, guys. And they extend from pectoralis fascia and are attached to the skin. There are 15 to 20 lactiferous ducts which open at the nipple. So we have seen the anatomy. So breast is a modified sweat gland and it extends vertically and horizontally. Vertically it extends from sternum to mid-axillary line or anterior mid-axillary line. And horizontally it extends from second rib to sixth rib. Sometimes it may also extend from clavicle to eighth rib. and axillary tail of Spence, which is a anatomical part which may extend into axilla, which is breast tissue, which may extend into axilla. Sometimes the prominent axillary tail of Spence may be mistaken as a breast lump, so we have to take due consideration while examining young female patients. So anatomy part, breast lies over the pectoral fascia muscle, pectoralis fascia. Then pectoralis fascia is just in front of the pectoralis muscle. So the pectoral fascia is present in between pectoralis muscle and breast. So usually breast may be sagging downwards. So to prevent sagging of breast, we have suspensory ligaments, which are suspensory ligaments of Cooper, which supports the breast, which are more on the lower half of the breast. This is upper half, this is lower half. So it is more present on the lower half of the breast, and they extend from pectoralis fascia to the skin, and they extend from pectoralis fascia and are attached to the skin. So in this way they prevent sagging of breast, and there are about 15 to 20 lactiferous ducts which open at the nipple. So if a cancer involves the suspensory ligaments of Cooper, it pulls the ligaments inwards, so there is a dimpling of skin. And if a cancer involves lactiferous duct, which it causes inward pulling of the nipple, which is called retraction of nipple. So these are the, see, we can see here dimpling and here retraction of nipple. Here dimpling is due to like inward see it is due to pulling of ligaments inwards due to cancer of suspensory ligaments of Cooper, and here retraction of nipple is due to a cancer of lactiferous duct. A lactiferous duct which open into, like there are 15 to 20 which open at the nipple. So this retraction of nipples may be like congenital or recent. Congenital may be resolved by exercises, but a recent retraction of nipple may be an issue which we have to look into further, because there is some pathology in recent retraction of nipple cases. So recent retraction can be slit or circumferential. Slit means ductal ectasia, or circumferential means malignancy. So this both dimpling and retraction of nipple are not the signs of skin involvement in breast cancer. Okay, if there is a skin involvement in breast cancer, we'll see PUD orange appearance, which is orange peel appearance of skin. The skin of breast resembles to orange peel. So here it is due to blockage of subdermal lymphatics. If it is present in cancer, it is a sign of skin involvement. So it is the most conspicuous sign of malignancy. Okay, so which is important here. And we'll see the functional unit of breast. See, the functional unit of breast is terminal duct lobular unit, which is a site for origin of major cancers. We have normal lobule, which converts into epithelial hyperplasia, which further converts into ductal carcinoma in situ, then invasive carcinoma. So these are the stages which undergoes in breast malignancies. And there are stromal cancers like fibroadenoma, which is a benign condition, then phyllodes tumor. So the function unit of breast is terminal duct lobular unit. Terminal duct lobular unit. Okay. Now we'll see the lymphatic drainage of the breast. So breast majorly it drains into axillary lymph nodes, and majorly it means, in the sense, 90% of breast lymph is drained by axillary lymph nodes, and only 10% is drained by internal mammary lymph nodes. So axillary lymph nodes on clinical examination, there are like 5 groups, like anterior, central, apical, lateral, posterior. We'll see how to remember axillary group of lymph nodes now. So if we see the diagram here, we have apical, which is present at the apex of the axilla. Then we have lateral groups. Then we have central groups, posterior groups, apex, lateral, central, posterior. If we imagine apex to be like in this shape, so first we have to see the diagram of axilla. So if we see here, we're going to observe. So we have apical group, then we have central group, then we have anterior, posterior, and lateral groups. So apical, central, anterior, posterior, and lateral. Apical, central, anterior, posterior, and lateral. On surgical divisions, which is divided by pectoralis minor muscle, we have lateral to pectoralis minor, behind pectoralis minor, and medial to pectoralis minor. So which is so axillary group of lymph nodes is divided like this. Okay. Here we have pectoralis minor muscle also. So we have lateral to pectoralis muscle, behind pectoralis muscle, and medial to pectoralis muscle. And internal mammary lymph nodes, which best range in 10%, which are from upper inner quadrant and lower inner quadrant. So if it is a breast, we have upper inner, upper outer, lower inner, lower outer. Here it is sternum. So this will be drained into internal mammary lymph nodes, this part, and the remaining will be axillary lymph nodes. Okay. Then we have rotor lymph node, which is interpectoral lymph node between pectoralis major and pectoralis minor. It falls under level 2, behind pectoralis minor. Rotor lymph node, interpectoral lymph nodes. So we have seen the anatomy part. So we'll just take a glance of breast part 1. So what is breast? Breast is a modified high So did you guys took a glance? So now we'll see the triple assessment. So the patient comes to your ward or to a surgical department with a lump in her breast. We have to first do triple assessment. As we all know what is triple assessment, we have three components. First clinical examination, we have to take the history, and then followed by radiological examination, and then followed by histopathology. So in radiological examination, if the patient is less than 40 years of age, we have to consider USG, and if the patient is more than 40 years of age, we have to consider a mammography. And histopathological examination, we have to do FNAC, which is fine needle non-aspiration cytology, and true cut biopsy. So why we have to consider mammography for only more than 40 years of 40 years age of women? We have to see, now we'll see why we have to consider only mammography for more than 40 years aged women. So in mammography, if you see young women like less than 40 years, if you see the mammo here, so glandular tissue will be appeared as white, and then fat is appeared as dark or black in color. So this is fat, which is black. And then we have glandular tissue. So in young females, like less than 40 years aged females, we see a more glandular tissue, due to which lump may be mistaken as a glandular tissue, and they may miss the diagnosis. But in more than 40 years of age, there will be more fatty content in the breast. So we can easily identify the lump in the breast. So guys, if you see, so we can easily identify a lump because there is a decreased glandular tissue and a more fat. So lump is also white, so we can easily identify a lump in elderly patients. So we do mammography, but if you do mammography in young, like less than 40 years of age of females, we may like miss the diagnosis. And then we have so this is what the explanation for why we have to do USG for a less than 40 years aged female and more than a mammography for more than 40 years aged female. So the important causes due to mammo due to mammography, no, due to glandular tissue, which is more in here and less here. We can easily identify the lump. Now we'll see clinical examination followed by history. We all know history will take another, like further we'll be seeing. So first clinical examination. So most common, like most best examination clinical method is dial clock method, like like how a dial clock works, like that. How a dial clock works, which is clockwise. We can also interpret it as lump at 1 o'clock position or lump at 2 o'clock, like that. Then we have vertical strike position, where we go up and down, up and down, up and down. Then we have horizontal strike position, like right to left, right to left, right to left, up and down. Okay. So dial clock method is the best examination technique and best interpretation method. Then we have imaging. First we'll see mammography. Mammography is the X-ray of the breast. Okay. Mammography is the X-ray of breast. ఓ మాయ ఈ ప్రేమ అంటే మాయ ఏ గోలా గోలా ఒక తీయనైన గోల. So 0.1 to 0.2 radiation is exposed. Two views are taken, which is craniocaudal and medial lateral oblique. In craniocaudal method, we keep breast in an instrument, we press it over the instrument because to get a more precise imaging. And then we have medial lateral oblique MLO technique, in which we more breast tissue is visualized in this, and axilla is best appreciated because we'll take consideration of oblique region also. Okay. uh, 3D mammo is the best because it is a latest form of mammography which is more sensitive and better results in a dense breast. So mammography is also two types, which is a screening and diagnostic type. Diagnostic is after 40 years of age, and screening when we have to screen. So it is a breast screening method mammography, and there is a 15 to 20% reduction in mortality. And annual mammography should be started at the age of 40 years of age. Okay, and if and we have to start screening by 35 years of age if there is a strong family history and there is a risk of breast cancer for more than 20%, which can be assessed by Gale index or BRCA proscore, BRCA gene mutation, BRCA, BRCA, and BRC mutation. And we have to start screening at the age of 25 years. uh, if there is a BRCA mutation is present, and first degree relative of patient with BRCA mutation. Okay. Mostly at 25 years, MRI is done as mammo is not sensitive, and at 30 to 35 years, it is switched to mammo if MRI is all clear. Okay, you have to like make a point of this. And then if breast density is high, MRI will be continued. Then we have diagnostic, which is at 40 years of age. So mammographic findings, benign tumor and malignant tumor. Benign tumor is well differentiated halo surrounding lesion is present, and there is a macro calcification, and in malignant irregular spiculated lesion and architectural distortion, and there are lymph nodes involvement and microcalcification. See mammography of benign lesion and malignant lesion, fibroadenoma. It is a craniocaudal thing. We have regular borders, well differentiated, surrounding halo is present, and there is macro calcification, and there is in the malignant lesion we have irregular, it is not well differentiated, irregular speculated architectural distortion and lymph node involvement, and there is micro calcification. Seen here oblique, we can also see axillary region, and we have to draw a line from axillary to nipple area. If a lump is present above the line, so if we see changes in above the line, we have to consider it as a lump in superior part. If you see changes in below the line, we have to consider it as a changes or a lump in inferior part of the breast. Okay. Now after all this, uh, after we have done the MRI or like mammo, You have to see BIRAT score. It is breast imaging reporting and data system. It is a standardized way of reporting mammography, USG or any MRI. And we have 0, 1, 2, 3, 4, 5, 6 scores. Mostly 7 if we consider 0 as 1. So category, it is incomplete investigation. If you have done mammo in 25 years old female, it may be considered as incomplete investigation. Here need additional imaging or prior examination. And then we have for management record additional imaging or private prior examination not available. In the first BIRAT score number, BIRAT score 1, it comes in a negative category. We have to do routine screening every year and essentially 0% of cancer. And if there is a BIRAT score of 2, it is a benign lesion. We have to consider routine screening and risk of cancer 0. If it is a BIRAT score of 3, probably benign, short interval follow-up like 6 months. This is 0 to 2% of risk of cancer. And the 4 is suspicious. We have to take a biopsy. And 4, we have 4A, B, C. A is low suspicion for malignancy 2 to 10%, and 4B is moderate 10 to 50, and 4 is high suspicion 50 to 95. Okay, and we have 5 is highly suggestive of malignancy, tissue diagnosis compulsory, and we have more than 90% of risk of cancer. And BIRAT score 6, biopsy proven malignancy, which is like surgical excision and clinically appropriate. Already we have also LIRADs for PIRADS thyroid, LIRADs for liver, PIRADs for prostate, PIRADs for thyroid, like thyroid, breast, liver, prostate. Then we have calcifications of breast, benign. There is a popcorn lesion, it is called fibroadenoma. If there is a lead pipe appearance, which is fat necrosis, which may mimic malignancy. The secondary trauma resolves with time. And broken needle, ductectasia, popcorn calcifications, fibroadenoma, and teacup, fibrocystic disease. So risk of malignancy or cancer for the following structures we see here. For clusters which have more, we have more risk than the linear, segmented, diffuse. Cleansed, mnemonic, risk of cancer, cluster, linear, segmental, diffuse. If patient uses talcum powder, it will look like diffuse microcalcification in mammo, so breast should be cleaned before mammo. And lymph node in mammo. In malignant, it is round, loss of halo and fatty hilum. And in benign, it is kidney shaped, fatty hilum is present. We will see USG and MRI. USG, it is imaging modality of choice. The difference between solid and cystic mass. A pregnant lady with a lump undergoes USG, and a young female with dense breast USG. These are indications. Then MRI indications are investigation of choice for breast implants. Linguini sign is a mean intracapsular rupture of implant. See, this is a Linguini sign, which is an intracapsular rupture of breast implant. And in USG, intracapsular rupture is in a step ladder pattern, and extracapsular rupture is seen as snowstorm appearance. And immediate treatment is removal of implant. And then MRI differentiate between multifocal and multicentric lesion. Multifocal means it is present on the same quadrant, and in multicentric, different quadrants. So in breast conservative surgery is contraindicated in multicentric malignancy. Okay, we have to remove the entire breast, not only the one quadrant. And it is the most sensitive investigation for ductal carcinoma in situ and imaging investigation of choice to identify local or scar appearance after surgery. And if the patient has received radiation after surgery, then an altered signal of MRI is seen for 6 to 9 months. So MRI should be for distant PET scan. And we have in a patient with suspected ductal lesion but not inclusive USG, which have to undergo MRI. And screen modality for young high risk patients, MRI. First degree relative patient with BRCA mutation which who does not want to get tested. In patient with BRCA mutation, Deformity syndrome, history of radiation exposure to chest wall. MRI screening from 25 years. And risk of breast cancer for 15 to 20. Gerinek BRCA postcode. Start screening at 35 years of age. Dense breast, family history. Then we have histopathology. FNAC and true cut biopsy. FNAC is a final aspiration. We use 23 to 30 gauge needle. It is only cytology, only cells are seen. In final non-aspiration, superficial lesions for like breast and thyroid. And in true cut biopsy, 23 to 30 gauge. 8 to 18 gauge needle is used. 16 is the best for breast biopsy. It is an incisional biopsy. Conjunctival instrument is used and also using skin tumor. Investigation of choice. Bye, guys. The session is completed, and please tell me how was the session. Okay.